Welcome back to another video with MD in Ireland. My name's Haley and this is my channel. Welcome to my cozy fireplace. If you hear weird dog noises, please excuse them because my dog has decided this is the moment for him to play. I apologize for the long length of time between this video and the last. I got busy and was on holiday, and then also wanted to do this video as much justice as I could and dragged my feet a little, so here we are. This video, as you can guess from the title, is about comparing the US versus the Irish healthcare system, both as like an employee within the system, as a provider in the system, as well as a patient in the system, and kind of what differences I've noticed. I'm not an expert. I was raised, trained, and practiced in the US healthcare system, and have only really been practicing in Ireland for about 5 months. So not an expert at all, but I wanted to put out a video detailing a little bit of what I've noticed for folks asking me questions. And so that's what we're here to talk about today. So before we get into the meat and potatoes of it, I want to talk a little bit about history. And I know you're thinking, Haley, this is left field. This is not why I'm here. Bear with me, there's a reason. I do think that the history really helps you understand kind of the current state and challenges that face the Irish healthcare system and allows for a little bit of grace for that. Just like the US and Ireland, the healthcare system is not perfect. It has its issues, which, are felt. And so I think it's important to allow grace for the history that explains why it may be the way it is. Again, I am not an expert. I did not know much about Ireland before, starting to plan to move here. I did end up doing a lot of research before I came here. There's definitely some podcasts that I would recommend, like the Irish Passport or the Irish History podcast, which really helped me kind of learn the socio-cultural, political kind of moment of Ireland. And so, of course, I take everything I say with a grain of salt. This is kind of what I've come to learn as a very, very brief overview of kind of the history of Ireland. Ireland is a country that's existed for a long, long time, with its own culture, customs, language, law, religion, you name it. And kind of starting, in the last 500 years, England started to try to exert its own control over Ireland. And in a lot of ways, Ireland was its first colony, the first British colony. And so England learned a lot of its tactics to systematically destroy an existing social-political order, a language, history, and the even nature in some instances. It deforested most of the island and to replace it with its own. And Ireland fought really hard during that time. In 1845, just before the famine, and I say it in quotations because it wasn't a famine, there was food, but the British wouldn't let the Irish eat the food. There was 8 million people in 1845, and then by 1901 there was 4.4 million people. So that's almost 4 million people that were lost either to death, unnecessary death, or forced to immigrate to like Australia and the US. And today the population is about 5.1 million, so they've been slowly trying to regain that population back. And then the other piece is the aging population. So you have in 1911, the average life expectancy in Ireland was 53 years of age. And that was, it was a product of a lot of things. I mean, the poverty that was facing the Irish folks, the malnutrition, disease that, comes with poverty, that life expectancy has rapidly, increased. It's now in the 70s. And so you have a big aging population, and yet not the system to quite meet that need either. When tasked with rebuilding and establishing themselves into a modern nation, they did kind of model a lot of their healthcare and their legal system on the system that they knew, which was the UK system. And so there is a lot of parallel there. And I think it's it's fair to say that the healthcare system here is incredibly overloaded, because not only are there a lot of people here, like the doctors who actually train here in Ireland, leaving, so leaving the country, the young folks, young educated folks, for better economic ventures, but you also have like people coming into the country, or elderly folks aging, that aren't really filling in the gap of needing providers. And so you have this huge dichotomy between demand and supply. And so there's definitely not enough doctors for the amount of people on the island. And that is felt in terms of how people experience the system, and how I, as a provider, experience the system. So let's talk about the healthcare system. So as most people probably watching this video knows, the US healthcare system is a multi-payer system, a lot of insurance, a lot of high costs, and a very huge disparity in terms of who gets care. In Ireland, technically it's a universal healthcare system, although as a doctor and as a patient, it doesn't quite feel that way, because so there's a such thing as called a medical card, which is basically free healthcare, right? But only certain people can qualify for this medical card, and the criteria is very strict. Even most Irish people don't qualify for the medical card. I certainly don't. And so people who don't have a medical card have to pay full price for bloods and prescriptions and consultants and surgeries. And while it's nowhere near as high as it would be in the States, it's still a cost, and it's still hard for a lot of people to pay. There is insurance that can come into play and help reimburse some of the costs that you might pay, although you do still have to pay the costs up front. And so as a doctor with a patient sitting in front of me, it honestly feels the same in terms of like how I have to weigh like where to refer someone in terms of what they can access based on their coverage, whether that's medical card, none, or insured. So let's talk about medicine. The medicine's the same. I mean, a human's a human, no matter where you are. I think what differs really is some of the prescriptions, some of the medications that might be available in the States aren't available here. Like for example, hydroxyzine, which I would prescribe for someone who has anxiety attacks. That's not something that they have here. There's like little things like that. There's also medications that they have here that they don't have in the States, especially for conditions like IBS. And so there's that difference, and even the medications that they do have might have different names here. Like, so the generic, of course, is the same, but the brand name is different, and everyone might refer to it as the brand name. And so there's little differences like that. And then there are certain conditions that are much more common here that you'd have to take into account, because as I mentioned, they had a huge loss of population. Anytime you have a bottleneck effect in a population, genetic conditions they go sky high. And so hemochromatosis is a relatively actually common condition here. We have quite a few folks with things like autism, and other kinds of more genetically predisposed conditions. And so certainly there's a little bit of like kind of a difference in the things you might see on the day-to-day. And the other thing here is like menopause, like HRT treatment is much more common here, while in the States I feel like it's just starting to get off the ground. The other thing that I found is measurement. So for example, like hemoglobin A1C, I would be looking for a number that's like 6.6, 6.5, 7, but they do it in a different measurement completely. And so you have to take into account, the new 6.5 is now 47. And so you kind of have to do these like calculations in your head or on Google or whatever it is to kind of convert results and the measurements that you're used to interpreting. Yeah, there's a lot of the little differences here. Like ultimately, like it translates, medicine is medicine, but like certain things are different. So let's talk about the GP experience, or the PCP experience. For kind of perspective, before I moved here, I worked in a FQHC, a federally qualified health center, that a really busy one as a PCP. And so that's kind of my baseline for a lot of my comparison here. And then prior to that was like a residency clinic, which also was similar to an FQHC in the way that it operated. So one big difference is the lack of like medical assistant or nursing support. So in the States, I usually would have an MA or a nurse rooming my patient, taking the vitals, asking for their primary complaint, and that would all be like updated in the chart before I walked into the room for my whatever 20-minute consultation. In Ireland, generally speaking, you as the doctor room, do your vitals, and do the entire visit on your own. And even in some clinics, you're doing like the bloods, although that's not as common anymore here. They're starting to move where nurses are doing more of the bloods. But there's next to no mid-levels. And this is again in a GP sphere. I can't speak to specialist sphere, but I do have to room and vital and everything. And I only have 15-minute consultations, which in Ireland is actually more than what was before. So they used to have only 10-minute consultations for all of that, like just generally in Ireland. And then more recently, like the ICGP, the Irish College of GPs, has kind of advocated for more 15-minute appointments just to give us a bit more time. And so, you know, it's a bit hectic at first to try to get used to 15-minute consultations where I'm doing all the vitals, I'm doing all the rooming of my patients, I'm running the urine samples, you know, I'm doing the swabs, like it's me, right? The social supports that people rely on, like parking permits and disability applications and wanting like a stair lift or a walk-in shower or whatever, like supports that they might need for conditions that fall under the government require GP letters. And so there is quite a lot of like admin and paperwork that is required. And at the same time, usually not a lot of time for admin, like actually built into the schedule, just because, again, of how much of a demand, like most clinics just can't afford to give you much admin time. And so that's something that also falls to GPs. The other thing is, which I found was kind of strange, was consultants or specialists, like let's say a rheumatologist or a psychiatrist will ask a GP to get bloods for their visits and ask us to write their prescription. So for example, I get like a script, a paper script written by a specialist, and then I am the one who has to then transcribe that prescription in my name to the pharmacy. For medications I'm not used to prescribing, like methotrexate and things like that, that usually a specialist writes the prescription and I don't have to get involved, right? So there's a lot more that falls onto the GP plate here than in the States, and specialists and consultants rely on us to do a lot of their more menial things, like the actual writing of prescriptions, and they're getting the bloods and all of that. And so, you know, good or bad, that's just kind of how it is. I know that the ICGP, again, is trying to advocate to change that. So consultants are responsible for their own bloods and for their own prescriptions. But for the moment, that's kind of where things are. There's also a limit in terms of practice. So, and I guess when I say that, I mean it's a subjective limit. Like, I haven't seen anything objectively saying, like, I as a GP cannot do this. But there's been a lot of things that is advised that I don't do, that I would do often in the States. Like, for example, writing for an SSRI script for a suicidal 16-year-old. Like, that is not something that is generally advised here. GPs writing mental health scripts for minors, anyone less than 18. And kind of the general consensus is, if I were to prescribe something to someone who's 16, let's say Lexapro or whatever, and something were to come about and I were to be sued, the ICGP would not defend me because it doesn't fall under like what a GP should do. There's a few other things, like adding a second psychiatric med to an adult. So say someone is on fluoxetine and you want to add a bupropion, like that is generally not advised. It's considered out of my training. And even though like it's not technically written that I shouldn't do it, it's just one of those things where like, you should be sending to a psychiatrist, because if a second agent is needed, it's now out of your wheelhouse. So there's little things like that. The other thing is starting insulin on patients is not something that's generally advised for GPs. They ask that we just send people to the A&E if we think that they need to start insulin. I will say I don't know any, and again, I'm new here, so this might not be the case, but I don't personally know any GPs that actually deliver their pregnant patients. We certainly do prenatal care, but most prenatal patients also are seeing OB-GYNs, who then are the ones that ultimately deliver their babies. And so I don't know how many GPs are actually doing like labor and delivery. You have to get signed off for like every little thing you want to do. So if you want to do joint injections or you want to do IUD insertions, you have to like get signed off by the ICGP to do them before it's advised that you do them, because if something were to happen, they would not come to your defense in the case of a suit, which I guess kind of goes nicely to the next point I have to say. Mentioned them a few times in this video. I haven't personally ever had one, knocking all the woods, but I've been cautioned by many colleagues to double cross my T's and dot my I's, because litigiousness is present in Ireland, I would say as much as the States, if not even a little more, to be honest. And as such, there's a lot of defensive medicine here, a lot of ordering of tests and imaging and bloods, and in terms of documentation as well, to cover your bases. And so that is something that is definitely present here, and that you have to be careful about. So let's talk about referrals. So I have a patient in front of me and I need to refer them to a hematologist. The experience of that patient and accessing that hematologist is going to vary greatly on what they can afford and what their coverage is. So there's a huge disparity there. So if I were to have a patient in front of me who needs to go to a hematologist that is a medical card patient, and say they just have a medical card, they have no insurance coverage, then more than likely, unless they have a pot of money, more than likely they're going to go through the public hospital route. So in Ireland, there's public and there's private hospitals. And as you can imagine, the public hospitals are extremely overloaded. They have long wait times. They have way too many patients to ratio of actual doctors. And the private hospitals are a bit more cush, and you're going to get seen quicker. And so if I were to have a patient in front of me who has a medical card, who I referred publicly to a hematologist, even if I wrote like urgent on the referral, they are probably not going to see a hematologist for at least a year, but it might not be up to 3 years. Those are the current wait times for most consultants and specialists here, is like 1 to 3 years if you go the public route, if you have medical card, right? So the free insurance route, or sorry, the free healthcare route, I mean. If my patient were insured and or had financial means to go privately, they could be seen within weeks. And so the difference is massive in terms of access to care and management of conditions publicly and privately. And I will say, I mean, Ireland's a small island. I mentioned 5.1 million people. It is smaller than the population of New York City, spread over a large island. And in some cases, there's only like for example, if we took pediatric neurosurgeons, there's 3 on this entire island, 3. So sometimes people have to go abroad for care. And there's actually like an entire system set up just for that, where people are going to Spain for a procedure, or wherever it may be, Denmark for a procedure. And so that's not uncommon that people have to go elsewhere within the EU to get care done. At times that care is through the medical card, so you can actually have it where, let's say I refer to a specialist and that specialist says, oh, this person needs to see like a really highly specialized provider that we don't have in Ireland, and so they need to go to Spain for this procedure or this whatever, and the Irish government will actually pay for that, the healthcare involved, not like the travel, but the healthcare involved to get it covered, because the person was initially referred and followed the public like medical card route. ERs, or what they're called here, accident and emergencies, A&Es. So A&E is another very long wait time. So if I were to have an accident and have to go to my local A&E, which I my spouse and I have done that, unfortunately. My spouse was waiting like 8 hours before they were seen, and that we were told was like a good scenario. I have had patients tell me that they weren't even talked to or had a doctor examine them until like 24 hours after they entered the A&E. And so, you know, there's definitely wait times involved. That is different, of course, if you were going privately to a private A&E. There's usually not enough beds. So my local hospital, I've had patients in the local public hospital had to be like in the hallways or sitting on chairs for days, while things were being done. And so it's a critical situation. They need doctors. In terms of consultant experiences, like I said, I can't fully speak for it. I will say kind of what I've noticed, which is consultants or specialists often are in hospital settings, and a lot of them are contracted with multiple hospitals because, again, they just don't have enough doctors. And so you might have a doctor who is technically licensed with 3 different hospitals and see patients in all 3. That's very common. It's a small pond. A lot of times registrars or residents essentially are doing the notes, and so I do think there's a better work-life balance because of longer consultations, and 2, generally like that you're probably going to have a little less to do as a consultant. Electronic health record system. I have been in many, I have like 5 different electronic health record systems over the course of my years of medical school, residency, and eventually the big boy job. It is like 10 years behind here. So we currently, in my clinic, and I think a lot of clinics use Socrates here. I think there's a few other systems, but Epic is not here. And nothing near Epic is here. So Socrates is the one that I use currently in my work. It's slow, it's clunky, it's a bit ancient, and I think I could be used to all those things, but there's a few like specific things that drive me crazy. One being that it's pretty much all of Socrates operate on a local server, meaning like it doesn't connect to anywhere else. So the only way that I can get actual consultant notes or bloods that were done elsewhere, anything that was not done within my clinic, is snail mail, like mailed to us and scanned into the chart. And that's like the only way. And I think that's the case for a lot of electronic health record systems in Ireland. And that's really frustrating. The other thing is AI and like scribing. So scribing doesn't really exist for us GPs. Like we certainly don't have any, and I also haven't heard of any practices having any. AI is just starting to kind of come in. We don't have it operationalized in our EHR, but I've been told it might happen soon. But that would certainly make a lot of difference in terms of just documentation burden. Yeah, so I think it's not perfect. I don't think any EHR is perfect, but it's certainly not as cush as some of the fancier ones in the States. I know I've talked a lot about just the logistics of the healthcare system and my experience with it. And a lot of it has not been, overwhelmingly positive. Like I said, we need to allow grace for the country just being relatively new in terms of like being a modern nation and dealing with a growth of the population and of the aging population. And so I think having grace is important. I think some of the good things that I've experienced in the Irish healthcare system is just how like lovely the people are. So my patients are extremely kind, and there's definitely like that good old family doctor feel where like I know every patient and their family and like and it's only been 5 months and I've started to like really have good continuity of care and good relationships with these people, and they're very, very kind and very generous and understanding. I think another thing I've noticed is not a lot of them have great health literacy, and there's a bit more of kind of almost East Coast medicine in terms of the States, where there's a lot more paternalistic leanings of medicine, which it can be good and bad, but it means that what it translates to in terms of my visits is like I have patients who are very willing to like accept what I have to say, and they trust my guidance, and they generally trust science a bit more than some of my other patients would in the States. I think vaccine uptake is really great here, which is nice with everything going on. And there's just not as much of distrust of the medical system as I experienced when I was in the States, and for good reason, but it's not something that I'm having to deal with a lot. In terms of GP practices themselves, so clinics, surgeries, I will say there is a lot of like independently owned small town practices here of doctors that have been here for decades. It is unfortunately following the way of the States, where slowly that's being weeded out and being replaced by like corporate healthcare. But I would say we're not even 50% the way there at the moment. There's still like a pretty good amount of alive and well independent private GP practices, which is great. And I do have a lot of geriatric patients, a lot of patients who are 60s, 70s, 80s. And so I'm having to use a lot of those muscles, my little geriatric muscles, my palliative care muscles. And I love medicine. So yeah, I think those are kind of some of the big things that I've noticed. Yeah, so I think that's it for my video today. I think there's obviously more to say on this topic, and I don't know everything, and I'm sure if I were to watch this video 6 months from now, I would disagree with some of the things I'm already saying, and so please point me out if you disagree, or if you have other thoughts or perspectives on things going on with the Irish healthcare system. If you were to ask me would I do it again, I would move here again if I was given the choice. There's kinks here, just like in the US healthcare system, but it's still a very rewarding experience overall. And I, as any other family doc or GP doc, I love having like continuity with my patients and like having a little community and family, if you will. And that is just as prevalent here. As I say in every video, nothing that I mentioned here is intended to be guidance or legal advice. And so please find and seek out your own truth, if you will, and take everything I say with a grain of salt. I just am trying to be useful for anyone who might have questions. So thank you again for watching this video. I'm sorry that it's, a little low production value here. Hope you enjoyed the now dying fire, and we'll see you in the next one. Bye.